In this video, we are going to talk about phalangeal fractures of the toes. Digital fractures are the most common injuries in the forefoot and are often underestimated. Population studies show an incidence of roughly 14 to 40 fractures per 10,000 people per year. The hallux is involved in about 14 to 38% of cases, but the most frequently injured phalanx is the proximal phalanx of the fifth toe. In general, fractures of the proximal phalanx are more common than fractures of the middle or distal phalanges. Lesser toe fractures are usually straightforward injuries that cause acute pain and difficulty walking, but only rarely lead to long-term disability. The great toe is different. Because it is crucial for balance and push-off during standing, walking, and running, displaced or unstable fractures of the proximal phalanx of the hallux must be reduced accurately to avoid dysfunction of the hallux interphalangeal or first metatarsophalangeal joint. Now, let's look at how these fractures occur. Two main mechanisms are responsible for most phalangeal fractures. The first is a direct blow, such as dropping a heavy object onto the foot. This usually produces a transverse or comminuted fracture. The second mechanism includes falls or sports injuries that cause hyperextension or hyperflexion, leading to avulsion fractures. A very common pattern is the stubbing injury of the toe, axial loading with a secondary varus or valgus force responsible for up to 3/4 of cases, and often resulting in the spiro or oblique fracture. This mechanism is especially prone to producing clinical deformity and can cause fracture dislocations of the interphalangeal joints. Indirect twisting mechanisms of the fixed forefoot are less frequent. Clinically, patients complain of tenderness and pain with ambulation. The toe is swollen, with localized pain on palpation, ecchymosis, and frequently a subungual hematoma when the distal phalanx is involved. Patients often report difficulty wearing normal shoes and pain in walking barefoot or in flexible footwear. Sometimes there is a history of acute deformity that was spontaneously or manually reduced before presentation. On physical examination, you must document vascular and neurologic status, look for soft tissue damage, and be alert for signs of compartment syndrome in more severe crush injuries. Radiographically, standard AP and lateral views of the forefoot are obtained to distinguish sprain, dislocation, and fracture, and to evaluate alignment. The book then introduces the OTA-AO classification, which is the only system that gives a detailed description of the fracture pattern for phalangeal fractures. The code has the format 88P. Similar to the metatarsals. To specify which toe is involved, an alphanumeric code is placed in parentheses. First toe T1, 2, second toe N1, 2, 3, third toe M1, 2, 3, fourth toe R1, 2, 3, and fifth toe L1, 2, 3. Now, I will walk you through the figures that illustrate this classification. In the first diagram, you see group A fractures, which are extra-articular and simple diaphyseal fractures. A1 represents proximal extra-articular fractures. A1.1 is a non-comminuted fracture at the base of the phalanx. A1.2 is a comminuted fracture in the same region. A2 shows diaphyseal non-comminuted fractures. A2.1 is spiral, A2.2 is oblique, and A2.3 is transverse. A3 is distal. A3.1 is a simple, non-comminuted fracture of the distal shaft or metaphysis, and A3.2 is a comminuted distal extra-articular fracture. The next figure moves to group B fractures, which are partial articular and diaphyseal wedge fractures. B1 is partial articular. B1.1 is an avulsion or split fracture, which can be medial unicondylar, lateral unicondylar, or a coronal split with either a volar or dorsal fragment. B2 covers diaphyseal wedge fractures. B2.1 is spiral, B2.2 is a bending wedge, and B2.3 is a fragmented wedge with multiple pieces. B3 is distal, partial articular, and mirrors the proximal patterns. B3.1 is an avulsion or split fracture with the same medial, lateral, and coronal split possibilities. B3.2 is a pure depression of the distal articular surface, and B3.3 is a combined split depression lesion. The last figure shows group C fractures, which are complete articular and comminuted diaphyseal fractures.
C1 represents proximal complete articular involvement. C1.1 is a non-hominided articular fracture with metaphyseal extension. C1.2 has a non-comminuted articular surface but a comminuted metaphysis. And C1.3 is comminuted both articularly and metaphyseally. C2 depicts diaphyseal comminuted fractures. C2.1 is a segmental shaft fracture with a separate intermediate fragment. And C2.2 is a complex comminuted diaphyseal pattern with multiple fragments. C3 is distal complete articular. C3.1 is a non-comminuted articular fracture with metaphyseal extension. C3.2 has a non-comminuted articular surface but a comminuted metaphysis. And C3.3 is a fully comminuted distal articular fracture. At the bottom of the page, the text explains how to interpret the scheme. The letter A, B, or C describes the overall complexity. Group A, extra-articular and simple shaft fractures. Group B, partial articular and diaphyseal wedge fractures. Group C, complete articular and highly comminuted diaphyseal injuries. The first numerical digit, 1, 2, or 3, tells you whether the fracture is located proximally, in the shaft, or distally. The second numeric digit describes the specific pattern, spiral, oblique, transverse, depression, split, comminuted, etc., which varies depending on the group and location. The key message is that this OTA-AO system gives a precise, standardized language to describe phalangeal fractures in research and communication. However, the authors emphasize that there are no solid data showing that this classification alone predicts outcome or directly determine the best treatment. It is primarily a descriptive tool that helps us organize the many different patterns of toe phalanx fractures.
Fractures of the phalanges are almost always painful, but in most cases they can be treated symptomatically, with simple immobilization and an early return to function. All non-displaced fractures, even if they involve the joint surface, can usually be managed with a stiff-soled shoe and protected weight bearing for about 2 to 3 weeks, gradually advancing as tolerated. Buddy taping the injured toe to its neighbor is very helpful. It decreases pain, adds stability, and reduces the risk of potentially unstable fracture patterns from shifting. When there is visible clinical deformity, reduction is required. Closed reduction is usually enough, and the final result is generally satisfactory. A digital block with local anesthetic may be needed to make the maneuver tolerable. Reduction is achieved using a combination of gravity traction and axial realignment of the toe. After the toe is correctly aligned, buddy taping is again the main way to maintain the reduction. With the great toe, holding the proximal fragment steady for reduction is usually not a problem. For the lesser toes, a simple trick is to place a pen or pencil in the web space just proximal to the fracture. This creates a 3-point bending force that helps realign the fragments. For extra-articular fractures, our goal is to restore overall axial and rotational alignment. Axial shortening by itself does not significantly impair function. What matters more is that the toe sits in line with its neighbors. The adequacy of the reduction is therefore judged clinically by the appearance of the toe relative to the others rather than only on the radiograph. The nail plate should point in a direction similar to the adjacent toes, and the toe should fit smoothly into the normal cascade of the forefoot. Once satisfactory alignment is obtained, the toe is buddy taped to its neighbor for added stability. A small roll of soft, non-absorbent material, such as lamb's wool or foam, should be placed in the web space to prevent skin maceration from moisture and pressure. In some great toe injuries, a short period of immobilization in a plaster or aluminum splint may be necessary to hold the reduction securely. Operative treatment is reserved for relatively rare situations. The main indications are gross instability, persistent intra-articular incongruity that cannot be corrected closed, and open fractures. Problems most often arise when there is an intra-articular fracture of the proximal phalanx of the hallux, or when there are multiple fractures involving the lesser pose. A markedly unstable fracture of the proximal or distal phalanx of the great toe should be reduced and fixed. This can be done with percutaneous K-wires or with small mini-fragment screws, depending on the pattern. Unstable interarticular fractures of the great toe, once adequately reduced, should be stabilized percutaneously to avoid late malalignment. Intraarticular and comminuted fractures of the proximal phalanx of the hallux may require a dorsal medial open approach with plate fixation, typically using a small 2.0 mm plate. Contraindications to surgery follow the usual orthopedic principles: poor patient condition, vascular compromise, local infection, or significant medical comorbidity. Hyperflexion dorsal avulsion fractures at the hallux interphalangeal joint can often be treated with extension splinting, but operative fixation is an option when we want to prevent chronic flexion deformity and subluxation. In some cases, residual deformity or plantar pressure problems make shoe wear difficult, and patients may benefit from shoes with extra depth and a wide toe box. Now, let's look at the radiographic images. In the first image, figure 6850, we see an AP radiograph of the foot. There is a displaced intraarticular fracture of the proximal phalanx of the great toe that has been fixed with 2 mini screws. The screws cross the fraction line and compress the articular fragment back into position, restoring the joint surface of the metaphalangeal joint. Figure 6851 shows a different scenario, an open grade 2 fracture of the distal phalanx of the great toe in an elderly woman. The preoperative AP and oblique views show a displaced fracture with soft tissue injury at the tip of the toe. After irrigation and debridement, an open reduction was performed, and a K-wire was placed across the interphalangeal joint to provide temporary stability. The postoperative AP and oblique views show the K-wire spanning the joint and holding the fracture in good alignment. The text notes that the K-wire is removed at 6 weeks once healing is underway. The treatment algorithm for phalangeal injuries brings all of these ideas together. At the top, all phalangeal injuries split into 3 main groups: metaphalangeal joint injuries, phalangeal fractures, and interphalangeal dislocations. For metaphalangeal joint injuries, one common pattern is a capsular avulsion fracture. These are usually treated non-operatively with a stiff-soled shoe or a steel-reinforced inlay to limit dorsiflexion of the joint. Another box represents dislocation of the first metaphalangeal joint, which is then linked into the hallux fracture pathway. Phalangeal fractures are then divided into hallux fractures and fractures at the lesser toes. For the lesser toes, the algorithm is simple: close reduction, followed by buddy taping in a rigid-soled shoe. For the hallux, fractures are subdivided into articular and extra-articular fractures. Extra-articular hallux fractures are treated with buddy taping and a rigid-soled shoe. Articular fractures are more complex and split based on fragment size. A small loose fragment is treated with excision and soft tissue repair. A larger articular fragment with a step-off requires reduction and fixation with K-wires or screws. The next layer of the algorithm uses the JOS classification. JOS type 1 injuries are classic dorsal dislocations of the first metaphalangeal joint with interposed south casu. The recommended management is an attempt at close reduction, although open reduction is often required. If the reduction is stable, treatment continues with tape dressing and a stiff salt shoe. If the reduction remains unstable, the joint is stabilized with transarticular K-wire fixation. JOS type 2 injuries are treated initially with closed reduction. If a stable reduction is obtained, tape dressing and a stiff salt shoe are adequate. If the reduction remains unstable, again, transarticular K-wire fixation is advised. Plantar dislocations of the first metaphalangeal joint are managed with closed reduction, followed by tape dressing and use of a stiff-soled shoe to protect the joint while it heals. Interphalangeal dislocations, separated on the right side of the algorithm, are treated with closed reduction and subsequent buddy taping of the affected toe to its neighbor. Finally, the text discusses potential pitfalls and preventative measures. If a fracture occurs in the setting of nail bed bleeding or laceration, it must be treated as an open fracture. The nail bed should be decompressed, thoroughly debrided, and repaired whenever possible. A major source of long-term problems is persistent abnormal alignment. Malalignment can interfere with shoe fit, cause pressure areas, and lead to soft corns between the toes from bony prominences. Rotational deformities are particularly troublesome because they disturb joint mechanics and can lead to progressive deformity over time. In very unstable injuries, 2 bends may be required to achieve adequate stabilization. Symptomatic late deformities are managed with corrective osteotomy, reduction, and pinning. Small chip fractures sometimes fail to unite. If they remain prominent and painful, they can simply be excised. Persistent pain from malunited fractures or post-traumatic arthritis in the joint can be treated with arthrosis or resection arthroplasty of the affected joint. In displaced interarticular fractures of the great toe in children and adolescents, reported complications include painful non-union and asymptomatic fibrous non-union, sometimes associated with avascular necrosis of the involved fragment. Taken together, these pages emphasize that most toe fractures can be treated with simple methods, stiff-soled shoes, buddy taping, and careful reduction, while reserving surgery for the hallux and for complex articular, unstable, or open injuries where precise restoration of joint alignment is crucial.